So now we'd like to introduce the second speaker, Dr. Nguyen from Yuan. So welcome. His topic is updating the approach to manage chronic tibial dissection.
Good morning, Chairman. Firstly, I thank you, Medtronic, for give me a chance to present my report here. My presentation is an approach to the chronic TBAD dissection. As you see, I have no disclosure. Aortic dissection is the most catastrophic event, and it was found in the decade of 50s. The first operation is an open fenestration done by Robert Shaw, and the incident is different from country to country. It's around 3 to 16 over 100,000 people. This is a chronic, so there is some difference between the chronic and the acute dissection and depends on the extent of anatomic, and so it will change the management and the prognosis of the diseases. For typing, there is depends on the chronicities. It can be classified as a hyperacute that happens less than 24 hours to chronic means more than 90 days. For the classification now, there has some changes from the very classical is Stanford and Debicki. Now some new changes. For example, the American change classification is classified into 3 types: AD, BBD, and ID. But from the European view, they choose another classification is TEM. I think it's very popular to every surgeon here, so I can pass by. For the chronic type B dissection, there's some features differently from the acute. That is, it can prevent into one of 3 scenarios. Mostly it's a post-operation type A. And the residual aortic aorta of the thoracic and abdominal still progress, and it becomes a chronic dissection. Another scenario is an untreated, uncomplicated type B, and it's still progressive. Or sometimes a chronic type B dissection happen to us with a dissection, and the patient will come to us with an acute lytical features. In that case, we have to treat it as an acute. Because of the dissection is a long time, so the intima flat is quite different from the acute. It's usually stiffer, and it's the problems of the treatment. And another aspect is the true lumens and the false lumen, as well as the entry and re-entry tear. That causes the duration of the treatment, and the ratio between the true and the false lumen, as well as the diameter of the entry and the re-entry, will decide the hemodynamics of the aorta. So it will cause we have to pay attention when we treat the chronic dissection. And for the presentation of clinics, a patient with chronic type B dissection can present us with a pain or some malperfusions. Now, the regular indications of the chronic dissection now is the dilation of the aorta with the maximum diameter is between 5 by 5 or over 6 centimeter. It needs to intervene. Otherwise, the patient come to us with a rapid development over 10 millimeter a year. Malperfusions. Nowadays, for the treatment of type B dissection, there's 3 with open or hybrid or total endovascular therapy. For the open surgery, it is well developed, and now it's almost on the gold standard for the chronic type B dissection. Usually it is a very invasive and the mortality is still around 8%, and the 5-year survival is around half, 50%. For the chronic type B dissection, especially the graft for 1, graft for 2, the extension operation may from the subclavian artery down to the bifurcation. So it's a very, very complicated and very long case. It requires most experienced surgeons to do the operation to get a bad result. In general, it needs a single lung ventilation. It needs the Hackler machine. In the Hackler machine, we can use a total Hackler machine CBP, or we can use a left heart bypass. And especially the patient must be let the temperature down around 32. Some surgeons come down to 38 centigrade degree. Some kind, it depends on the situation. If we can clamp the proximal end, so we no need to stop the heart, it means that we don't use the catheterization. In some case, it some difficult case that the lung is very bad and we can attach to the edge of the preparation. Sometimes we have to need to stop the heart by circulation arrest, and the temperature can go down to 18 degrees. So it's a very complicated, and it makes very difficulty for the coagulations when we start again, especially with a very long extension of the aorta. We have use the spinal cord drainage. And the other problems of the open surgery is the problems of protection of the organs in the abdomen, especially kidneys and small intestine. So the operation is quite complicated. Still, it's very valuable. For example, especially for connective tissue disease. Like this case, so we is a MAM patient. The first operation is a root operation with the Tyrone David implantation and changing the ascending and hemiarch. And the patient came up to us 3 years later with a very huge thoracic abdominal aneurysm dissection. The arch is still dissected, but the diameter is not too big. So we decide to change the thoracic and abdominal arteries from the subclavian artery down to the infrarenal aorta, because we are lucky that the dissection stopped at the infrarenal part. So in the case, it is a picture of post-op. We use prosthesis, diaphragm prosthesis, make anastomosis. Make an anastomosis just after the left subclavian artery. So, and the distal is infrarenal artery, and we make hand make 4 grafts. We use the two wide prosthesis connect to the long prosthesis here to make 4 grafts to 2 kidneys as SMA and celiac. This is a long operation. Another case that we need to do the open version is because this patient is around 30, and he was operated 2 times before coming to us. It was firstly it was a rupture of the thoracic aorta just above the subclavian, the diaphragm. And the vast surgeon we will change by prosthesis. After that, this is the false aneurysm between the prosthesis and the abdominal artery, and they debranching the vessel of the kidney and put the stent. But 2 years later, there is a false aneurysm of the end of the stent, and the right kidney was occluded. This patient was a hypoplasty of the left kidney, so he survived only one kidney, and the main vessel to the kidney was occluded by the stent. So in this case, we have to do the reopen, and we have to put a graft changing up down, and take this is the graft, and we implanted the right kidney, and surprisingly, before the operation, the kidney function is very bad. EGFR is around 30 millimeter. But after the operation, we re-implantation the right kidney artery, and the kidney works better, and the EGFR increased to 100, nearly normal. So I think it will be a very good long term, and the kidney we will protect it good. For the hybrid surgery, the advantages of the hybrid surgery is no needs the Hackler machine, but it still did the spinal cord drainage. In the hybrid operation, it means that the branching is used of the branches of the organs in the abdominal. We still have to take the protection of the organ kidneys. And the running socks of the prosthesis may be in the descending thoracic aorta or in the infrarenal abdominal. But when you deal with the chronic dissection, because the thoracic is dissection, and if we are lucky that the infrarenal is still okay, so we can use the running socks from the infrarenal. But because usually for the chronic dissection, the true lumen is very, very small. So if we use the infrarenal abdominal aorta as the running source, maybe the blood coming to the kidney or to SMA, to celiac, maybe not enough. So we have to think about that. For the aneurysms, so we can do the graft from the descending or the suprarenal. So, well, we can see here for the two cases, it's around 89 patients, 79 patients. This is usually you see for the aorta is extended, not localized. This patient has aortic regurgitation severely, but the valve is small. But aneurysm of the ascending and the arch, and some parts of the descending aorta. So we did first operation is we changed the aortic valve and replaced the ascending and the arch, and the first third of the descending aorta. If it's with the graft. And this patient has an aneurysm here, down here. And the next operation, we have to do the debranching. Because this patient, the abdominal aorta is still good. So we make 5 branches from the common iliac artery to the kidneys. Because this patient, the left kidney has 2 branches. And the left kidney artery has 2 branches, so we have to only solve totally 5. And after that, we put the stent landing on the prosthesis, ductal prosthesis up, and on the native aorta down. For mention to the questions, Professor Puras's question this morning, we usually and always at least 5 centimeter length. And the oversight is at least 25% to put a graft on the vascular prosthesis. The second example here is this thoracoabdominal aneurysms, and we decide to use running socks from the thoracic, and we make 4 grafts to 4 branches at the abdominal. and after that we put the stent down here. So these are hybrid, but it's still less, more invasive. The third treatment for the chronic type B dissection is total endovascular. To do the total endovascular surgery therapy, it will need CD3D. I myself have no experience about this because in Vietnam we have no 3CD angiogram, and in Vietnam there is only 2 cases from one vascular surgeon did the case. So I'd like to talk some method of the endovas. You can see, and we can think about the strategies to do. This is basic code. Everything we know very familiar to this, and this is stabilized with the Nick Booker technique. That is dilation with a balloon to rupture the intima to close the false lumen in the thoracic. And this is a multi-layer parallel stent graft. This is so complicated, and this is the most popular is fenestratic and branch. In the mention this you see this is a big to do this we need the space. The main idea of this technique is to need space. So it's not necessary the distance between the origin of the stent graft and the native origin close together. It can have a distance so that from this distance the vascular surgeon can cannulate the artery. But the main idea is the space. So in the chronic type B dissection, when the true lumen is very, very small, so it's very hard to do this technique. I think Professor Chen Su has a lot of experience about that because your center is very high level. And this is some is candy and double sling. So in general, for the endovascular repair, there are 2 types. One is one kind is the trans through the true lumen to repair, and the other is through the false lumen to repair. There are many methods, but every method you will have some disadvantage. For the branch and fenestratic, so it is used popularly. But when the true lumen is stenosis, so it will hurt. For the TBAD only, so for the TBAD only, because the TBAD is just treat the entry, but they don't treat the re-entry. For the chronic dissection, there are 2 problems. First, the entry, and the problem is more difficult is the re-entry. If we just close the entry and the re-entry is still open, so the false lumen will increase and re-increase, and finally it will rupture. It's the main principle and the main pitfall of the chronic dissection. So TBAD only is not enough. For verticals and stabilize or something there is a very still risk of aortic rupture, so it's less used. For the false lumen repair, there's false embolizations and candy blood. This is an alternative method to combine with TBAD to solve totally the problem of chronic dissection. For the endo repair, it needs time to do the intervention, and it needs very modern and high resolution CT scan with hybrid operating, so we can reduce the time of operation. So in conclusion, that for the chronic TB, we have to individualize. So we have to choose the patient anatomy, the patient chronicity to fix the problem. And one that we can mention here is TBAD alone is not recommended. And that's we have to remember. Chronic TB is still challenging, and till now, 2022, there's no conclusion between the way to treat the TB dissection. And as I agree with Punrasit, why do we wait to chronic? That is very complicated. So should we intervene the acute TB dissection earlier, so we don't have to treat with very difficult TB chronic dissection. Thank you very much.
Thank you, Dr. Nguyen Thai. Very nice talk. So, no matter endo procedure, open procedure to treat the chronic dissection is very challenging. So nowadays, except what's introduced a different kind of technique in China now. So we use the Chiswell, we use the bronze to treat the distal site. But anyway, I suppose your final opinion is very important. Never let the patient turn to be canonical dissection. So, So I suppose maybe in the future, the guidelines for the TBAD dissection for the acute one maybe change or not. So what's the meaning of the stabilized TBAD dissection? What's the unstable, uncomplicated? It's very complicated. So I suppose to the acute dissection, it's really that maybe we should do TIWA first. Never let turn to be chronic. So how about opinions are Professor Bong and Professor Lapong? Yes.
I have one question about the debranching, visual debranching. I also performed some of that case, and eventually unlucky case. I have one case that have the aortoenteric fistula from the debranching graft. What is the tissue that you use to cover all of the graft that go into the SMA, go into the celiac, and go into the renal, both renals?
I'm sorry. What kind of fistula?
Aortoenteric fistula from the
Intestinal.
Yes, intestinal enteric.
Yeah.
Yes.
For the intestinal, it is very severe, complicated, but it's not. It's less severe than the outer esophagus, the fistula. In my experience, all the visceral branches was debranched with thoracoabdominal incisions, and we have that complications. But with outer intestinal fistula, there are two kinds, and it depends on the situation. Usually, some surgeons refer the extra-anatomic bypass, but I think, in my opinion, in our hospital experience that was done by the vascular, we can use the bovine pericardium to make a tube, so to solve the problem. And because when we open the abdomen, so there are lots of omentum, so we can use omentum cover. We have experience with outer esophageal fistula. We do like that. It's very complicated. We have to cut all the aorta. We replaced with a bovine pericardium like a tube. And after that we have to open the abdomen to use the omentum to cover the tip, and for the mediastinum abscess we have to varnish not varnish only, but we have to it means that to use gentamicin in and out, and we have to stabilize. We have the so for patient no need no eat, and after 2 months, if everything is okay, we still keep the jejunostomy, and after that about 6 months, when the patient will have come back, and we have stomach plasty to recover the eating root. Sorry. Well, this is very complicated, and the problem is that because our hospital is a referral hospital, if the vast surgeon, when we do the TIVA and they recognize the complication early and the transfer early, so we can save the patient. If they come with a very severe multi-organ failure, very severe infection, we can do that, but the patient cannot survive because of the infections. Thank you.